Good day. This is Russell Hendrickson with Practical Data Solutions. I'm the CEO here. Thank you for joining us today for Measuring Physician Performance in an Era of Reducing Costs, our webinar topic. Joining me is Becky Cook, who's an executive consultant with PDS.
Thank you, Russell, for the invitation to join you. Today we're going to be talking about physician performance and reducing total medical cost.
Today, the visualization tools, they allow us to build visualizations, and many of you may be working with this type of data where you've mapped out physician productivity with RVUs, maybe you've aligned things like coding or billing lag, and you can build them into very powerful visualizations. The one that we're showing on the screen here is actually built into Tableau, and it is categorizing physicians' productivity levels and stratifying them across their RVU performance. But, a power visualization is only as good as having the right metrics that tell the story and communicate effectively. And although this may be very powerful for analysis, it may not exactly focus to what a physician needs to understand to measure their performance. So that's really the focus of today's webinar, is to talk about and cover what are the right metrics. How do we set the stage to position those metrics to communicate effectively? How do we address or handle physician pushback? That doesn't apply to me, you're not recording the data correctly. And how do we really use statistical data effectively, with the ultimate goal of closing the gaps and at the same time trying to communicate effectively with the physicians? So why do we want to assess physician performance?
Russell, I think that goes back to the first topic that we were going to talk about, which is selecting the metrics. The metrics are very much based on what you need to measure. If you're looking for meaningful use, you're going to have different statistics than if you're looking to communicate with physicians or with your practice administration or hospital administration. So I think the first step that we recommend is deciding what you need to measure and then picking the metrics. Changes in healthcare are demanding more use of data right now, but we need data that actually talks to us in a meaningful way. Just creating a dashboard of numbers is not where we need to go and not what we see needed in the marketplace. So our first recommendation is really to start with accessible and familiar information on your dashboard and in selecting your metrics.
Excellent. And the key then is really starting potentially with a single page dashboard. If you're not doing this or you're not presenting information to physicians, oftentimes I hear when working with practices, well, our physicians get all these metrics. Yeah, but they might get them in 10 or 12 different reports. Well, that's very hard to make sense of. So, one of the key places we recommend to start is a single page and start with the easy metrics that you might have. So, Becky, do you want us to walk through this dashboard here?
Sure. So one of the first things you'll see is there are 5 important pictures on this particular dashboard. We have work RVUs that should be familiar to most of our physicians and care teams. We have visit or E&M codes. We have appointment data. We want to make sure that we're getting our appointments in, getting our patients in to be seen in a timely manner. And we also have our patient satisfaction data in here. So this is kind of a well-balanced look at what the physician needs to monitor their own productivity.
There's 2 other areas on the dashboard that I like to highlight. So it's clearly the charts and graphs right in the center. They highlight where we want to focus the physician. But my experience is that there's certain people that like to see a real snapshot, a tight summary of what's going on. So we have those same metrics across the top of the screen here in kind of a very quick crosstab. And then down the side, we have the quick answers. And what's nice about the quick answers is you really can't miss that there are green checks or, in this case, a red X, that this physician isn't meeting their care provider, clinical target. They're just shy, so you can't really miss that.
So Russell, I think one of the key points from this dashboard, as well as the next one that we're going to show, is to take this familiar data and combine it to create metrics that have some value to the physician. So here you've seen us comparing work RVUs to prior year. But some of the other easy comparisons that we can do are creating normalized data using percentages. So if, for instance, if we want to look at coding data, that lends itself well to using percentages down in the lower left-hand corner. Using work RVUs to visit ratios is a very meaningful statistic in the middle of the page. Reinforcing those new ideas is one of the keys to effective change management and to getting physicians to use the data, getting the care teams used to looking at this data with the physician perhaps. And so we need to reinforce these ideas with the physicians. And we have a kind of a unique way here to do that.
A couple other points I'd like to stress, and oftentimes initially, if you're not really focused and you're not providing this kind of information, you may want to start with paper. I know that may seem counterintuitive in this electronic age, but being able to sit down with printed versions of what they should be looking at, allowing them to take notes, mark up the dashboards, et cetera, and understanding, and then of course making sure that we have executive support behind that is also really useful. In addition, right, of course, we want to make sure that if we want to dig into data, that it's easy for a physician to understand, that they can get answers to what exactly are we looking at. So if I pull up this same dashboard live here, you'll notice I can hover over the explain and very quickly see what exactly is the metric that we're looking at. What is the description? Do we want to put more information in? How is it generated? We could even put more information about the fact that this chart here is comparing both external benchmark and internal department peer comparison, so making it very easy. And in addition, then we can click on the Analyze button and have the tool actually allow the physician to have access to detail behind the data or behind the report. In this case now, I'm actually in my analytics. I can see coding and curves. I can make changes, adding other dimensions. Or if I just want to see all the patients that I'm coding at level 5, the analytics allows me to slice and dice and then even drill all the way down to the patient level. This often handles questions about transparency of data, accuracy of data, where are you getting that number in my dashboard? And my experience is most of the time, once they've initially seen that you can validate the metrics in your dashboards, the number of challenges that comes after the fact tends to lessen because you've built confidence in the reporting and the tools and the metrics you're sharing.
Great, Russell. I think that really is helpful, is giving the readers immediate access to that type of information. It really saves a lot of quandary about it takes me a day or two to get a report run and give it back to the reader so that they get comfortable with the data. Another data set that we need to be working with just as closely as physician productivity data is contract metrics and quality measures. Now, these are really key to enforcing the revenue that we earn from seeing our patient, making sure we get all of our incentive payments and all of our quality measure payments. But also, these statistics and metrics go to managing the total cost of care, the subject of our webinar today. We know that physicians don't always view these contract metrics as good measures of outcomes, of patient outcomes, and we always get pushback on that. The thing that we really need physicians to acknowledge, though, and our care teams to acknowledge, is that these statistics are used to manage the financial success of our practices and the cost of care, particularly risk statistics. And so we need to provide them the detailed information to develop confidence that these scores are being used correctly and that they can impact the scores. So we generally do that by using peer scores. We provide things like a count of the eligible patients so that the physician and care team can verify that those are the right patients. And then looking at things like a gap to close count to make these more actionable for the physicians.
So here's an example of a dashboard that lays out the very points that Becky was just sharing. Here we can see for a particular physician, how many patients do we have in total in the panel? How many of those patients have HCCs? In this case, we see there's 33. The number of HCCs those patients have, the average HCC score per patient. And if you notice right underneath, you'll see the change from the prior year. So it's very easy to see that we've moved up. We have more patients. We have more HCCs. Even the acuity of the patients, the number of HCCs per patient has gone up. We also can see if there's suspects or patients that potentially should be seen or should be tracked or fall into these risk categories that need to be followed up through. So it makes it very easy at a glance to understand what has to be done and then where do we sit. We can also then see a very quick breakdown of the HCC categories, the number of patients that fall into those primary categories, and the chronic conditions and the change in chronic conditions as they move. So again, a dashboard, very clear, limited number of metrics, but very focused to help tell the story.
And again, communication of this data is really critical because most physicians, care teams are not used to using this type of data and looking at risk acuity of their patients. They're doing it mentally. They think they know who their high-risk patients are, and many times they do. But in the case of this information, because it is more complex and less familiar, what we've done is we've actually put hints on how to use the dashboard right at the bottom so they're very visible. They don't even have to use a flyover or point to something to see those scores, and how to use the information and the definitions. So we think that that's recommended part of our communication protocol. So most of this data is used to help measure cost of care for the patients. And what we hear all the time is, well, my patients are sicker. The data is wrong. And I think one of the ways that we work with this type of pushback is really to provide the statistical data as well as the backup so that the care team can see that we're actually finding all of their diabetic patients, for instance.
So one of the ways that we can do that is building in that gap performance reporting, understanding where the gaps are. And through the analytics, this is a much more sophisticated visualization looking across physicians, but very useful as a tool where we've shown the physicians individually what they need to see, but then as management, we can quickly identify and right away point and filter on where we might have care gaps, where are we missing care follow-ups, where are we not appropriately coding to the patients, and then continue to look down and say, well, who are our high-risk patients? Where do those gaps sit? Which physicians are on track or have the most patients that need that follow-up care, potentially where we're seeing gaps in the data, using our own data, we can start to understand how do we manage their costs by making sure we're managing their care. So one of the objections I hear many times is, well, our contract is for quality is through the payer, and the payer is the only one that has the right data. But the example of this visualization, this can actually be built using data within the practice and can be done in some cases more accurately than the data coming from the payer. But on the other side, the payer is telling a story, and we need to be able to understand and work with that payer data. Becky, can you speak to the limitations of the payer data?
Well, the data that I have seen coming from the payers is more difficult to work with, mostly because we can't always verify the data. Generally, the payers have had their care teams, their care management people come in and work with the data, extract data. They've loaded diagnosis codes that we don't necessarily have in our internal data sets. And you have to be prepared to download all the details and recalculate it yourself, or to use your own internal data. I prefer to use my own internal data because it's believable and it's positive and it's readily available, easy to work with, and the physicians have confidence that we're actually finding all of their patients. It's a relatively straightforward data set to find. It's built differently than the rest of our data sets. It's patient-based, patient-centric rather than physician-centric. And it's data that you typically can't get out of your electronic medical record in an easy way either. One of the things that I always am surprised at is physicians assure me that they know all of their diabetic patients and they're all being managed accurately. And they're all getting their hemoglobin A1Cs. When we start to look at data in this type of format, patient-centric, and actually scoring the metrics for them, what we see is the gaps start to fall out. And it's easier for the physician to kind of understand and take ownership of and believe the analytics when they see that, they've missed about 10 or 15% of their diabetic patients. We also then build confidence in the use of our internal data to go back and to reconcile that to the payer quality metrics.
I think this is a great example of you can't manage what you can't measure, right? So being able to understand where those gaps exist with the payer data, being able to compare the payer data to your own internal data to understand, potentially is the payer missing or not getting all the information? Because, as often as people go back to, well, the data is all sitting in my EHR, the payer's number one source for getting and scoring quality contracts is through the billing data that's coming through. So being able to understand that gap, and speaking with some of our practices that are looking at that, they've seen inaccuracies in the payer data of 5 to 10%. When you multiply that across a multi-specialty group practice, that has 100 patients, a 5 or 10% variance can be a significant amount of revenue that the payer is saying you're not eligible for, when in fact your own data may be supportive to reimbursement to that. But in either case, as you're looking and managing data, you've got to be able to provide that information back to the physicians where their care gaps are.
So Russell, in this example, what we've actually done is taking the payer quality metrics, but we've applied our internal data to it as well as the payer data. So you can see that we've calculated an individual score here in the middle, and we've compared that to what the Aetna award scale is so that the physician can see where they sit as comparison to the goal. We've also given them a comparative red or green dot to their peers, which we think is an important comparison. Where do they sit compared to the rest of the practice? And then on the end, we've shown them the total patients that are eligible for this measure, as well as the patients that they would need to see yet in order to achieve 100% of the goal. This is really an important piece of the communication process as well, is breaking down this information into actionable or doable steps. When the physicians first see some of these metrics, they think, oh my gosh, I've got 400 diabetic patients. How am I ever going to see all these? And we got a late start in the year. When you start to break this down as to how many of these patients they've already seen in their routine office visits and how many more they need to see, then this becomes a much more acceptable process for the physicians to get involved in, because everyone can get those last 2 patients in before the end of the year. You know, they put their staff busy calling the patients and asking them to come in, and that we need to get a check on their hypertension before the end of the year. Patients are quite willing to do this.
You know, I think the use of this arrow within the bar, if you were to just look at the percentages, Becky, to reinforce your point, we can see we're close to hitting the aqua section here, which is the Aetna award scale as an example. Yet when you look over to the right and you see it's really only 2 more patients, you realize moving that needle is really not that hard. And I think very effective way to have physicians understanding, like you said, getting them engaged. The right set of metrics. We don't need a page full of metrics. The payers oftentimes send back those long crosstab reports that's like trying to decipher code, right? So breaking down just what they need to see, putting just the metrics on the page and making it easy to understand the goal. It's very easy to communicate and then to engage.
Yep, and then being able to see those actually patient names that are missing completes the picture for the physician and the care team. So I think communicating performance like this can always be difficult. I find that difficult conversations work better in small increments. Instead of giving them all 10 metrics that Aetna's looking for, I might start with 2 or 3. And I might start with those that are grouped together, for instance, all the diabetic measures, that you can do all of the work at one time. We want to make sure that we're meeting our goal, which is creating improvement. So structuring the data and the statistics in ways that the physician can think about them creatively, because these are very creative, thoughtful people. You want to find ways for the readers to find their own solutions, because my solution as an administrator is often not what the physician perceives as the best solution. So I find that making sure that the data is presented in multiple formats and that it is open-ended so that the physicians can find the solutions and the care teams can prompt with suggestions works best.
So the challenges faced by practices when we think through what we've shared here is, from a technical side, oftentimes is that the data is not summarized. Certainly any kind of clinical or quality measures, it's very hard to get the data summarized up without a good set of tools or technology. We have a lot of tools to present graphics, but how do we present them effectively to communicate? And effectively, I would also include efficiently, right? So if you look at some of the reporting you may be doing or the volume of data, how do we then assemble those sources of data together and then simplify it down so it's communicating clearly and effectively in what is, I call, a true dashboard. The term dashboard, think about when you're driving, you want to be able to glance down, pick up 4 or 5 key indicators and continue where you're headed. Well, the same thing holds true, right? Especially when we're communicating with physicians. So we've got to assemble that data so it's easy and quickly. And then, of course, we have to have the accuracy and the content behind it so that if somebody wants to verify, drill, or focus in on the gaps, we can do that. So it's really about making information meaningful.
As we think today about some of the data that we've presented and some of the ideas, we come back to assessing performance, and especially in this era of trying to reduce the total cost of care, it really comes back to looking at which metrics do we need to select and making sure that we're using them correctly. You know, these risk statistics, the statistics on acuity of care really drive your care management initiatives. It drives the revenues that you're going to increase through your programs, your incentives, your clinical quality goals, and really the cost of not managing these new revenue streams, managing the appropriate patients or managing them in the appropriate way. So the ways that we're moving with new sources of data and new metrics is really important as we try to manage the cost of care and reduce the cost of care. We have to make sure that we're choosing our metrics closely, carefully. We have to be able to deal with the change management processes, verify that we're using the data correctly, and mostly that we're communicating all along the way. One of the most effective ways is to make sure that our communication is timely, that it is systematic, as in we present the data weekly, monthly, quarterly, whatever frequency we choose, but that it be done consistently and on time so that it is available for the care teams to utilize.
I would also challenge, along the way, healthcare is changed very quickly in the last few years, faster than certainly I've ever seen it change. If you're communicating, which I'm sure all of our practices, and you are communicating metrics to physicians, or you're managing on dashboards or reports, are they meaningful today? Are they focused? Have they sort of grown into, I might have started with a handful of metrics, but every year or every period we added more and more and more. And my experience, again, working with practices is that in some cases those dashboards just become everything. You just keep adding and adding and adding. And maybe is it time to streamline them, to step back and say, what do we really do? Does this dashboard really focus the physician and help them to quickly see all of the areas that we talked about? So I challenge, if most organizations are doing reporting, or is to step back, take a minute and say, is it communicating effectively to what we're trying to measure or manage to today?
We should also mention, Russell, that if we've touched on a topic today that you would like to hear about in more depth, we have contact information for you. And we do routinely offer workshops for customers as well as webinars that go into a little bit more depth on some of these topics. You are welcome to join us for those as well.
Yep. Thank you so much, Becky, for sharing, and thank you all for attending today. And this will conclude our webinar, and we hope to see you at upcoming webinars or hear from you soon. Thanks so much.